Welcome to Moving Conversations, a podcast for movement professionals by movement professionals. If you coach, train, or teach movement, Pilates, or fitness, then this podcast is for you. With more than 60 years of experience in fitness and Pilates, your hosts, Brian Ritchie and Nora St. John, explore the science of human movement, diving deep into the facts, myths, and common misconceptions, hoping to spark thought and conversation about how we view fitness and movement. Now, let's jump into Moving Conversations. And welcome back to Moving Conversations. I'm Brian Ritchie. Joining me as always is Nora St. John. Good morning, Nora. How are you doing?
Very well, Brian. We finally have some sunshine out here in California, which is really what, we deserve because we're Californians. So I'm very happy about that.
I like what you deserve. Oh,
we do. This is why you live in California, so you get sun.
Yeah, we're about to get that rain and stuff that was on the West Coast is about to hit here tomorrow. So that should be a lot of fun driving in. So yeah,
on Thanksgiving, which is everybody's favorite day to drive. Anyway,
exactly. So today we have part 3. We're going to jump into part 3 of getting back into action, where we're going to be discussing low back issues. Today we're going to be talking about the disc. But before we do that, want to remind everybody to please hit the like and subscribe button. Okay, so on the platform of your choice, it'll just drop right into your email slot or your podcast slot or wherever it is. So you get it Tuesday morning. It's there right when you wake up. You can check us out on YouTube under my name, Brian Ritchie, and see us actually doing things with our hands. We figured out the technical difficulties. Hopefully we're crossing our figures from last week. Last week we had some technical difficulties. So hopefully that's taken care of. You can always reach us at movieconvos@gmail.com as well. So now with that behind us, let's dive into the discs.
So Brian, I'm going to start with you.
Okay.
So remember, a lot of this is based on Brian's book, which again, he's gone through a really wonderful, systematic way of looking at all the different back injuries and simple things that you as either a trainer or you as a person who has a back problem can work with. So when you think about the discs, we're often thinking about the symptoms of a disc injury, and they're a little different than the symptoms of some of our bony issues that we talked about last week, like osteoarthritis and stenosis and that kind of thing. And they really can be as simple as just localized low back pain to much more, a lot of sciatica is really common with disc injuries.
Yeah.
So to nerve pain that goes down the leg, that goes zinging here and there, goes down into the foot, creates numbness, creates muscular weakness, all the things we've talked about with the sciatic nerve being impinged. That's usually kind of one of the issues that you'll get with disc injuries.
Yeah. The disc is an interesting cat. They say 30% of people with disc injuries have no symptoms whatsoever. They have no low back pain. And what I remind people of is, look, you can have disc issues, much like you can have knee issues. People who have lived life to any extent are going to have things like a little bit of cartilage issue in the knee and the hip and a little bit of arthritis and all of that, just wear and tear over life. Well, guess what? You may have a little bit of a bulging disc or even a herniated disc, but if it's not touching on the nerve, it may never disturb you. You may never have an issue. There have been many, very, popular cases written about where people, had passed away, no low back pain in their whole life, but upon dissection, they found, wow, look at this massive disc herniation, but it just never touched on the nerve.
So that lets us know that if there's just a disc problem, again, the disc is deteriorated, the disc has shrunk, the disc is weakened and the walls are weakened. And so things are kind of poking out of it. If it isn't impacting the nerves, it often is not causing trouble. So that's an important thing to know. I'd also like to start, one of the things I like to think about here, and I learned this from Eric Franklin, was I often think about the discs as being a problem. Like just in my mind, discs are a problem. And I wanted to kind of take a step back from that mindset and really realize like discs are really important.
Yes.
So discs are these little, they really do think of them as kind of a jelly donut. It's like a fibrous ring with kind of a pulpy middle. And that basically creates that connection between the vertebra. It creates a cushion so that when we breathe in and breathe out, as simple as breathing in and breathing out, that disc will get gently expanded as we get a little taller, and compressed as we exhale and get a little shorter. So the discs are in this constant state of dynamic action with everything we do, whether we're moving, whether we're rotating, whether we're walking, even when we're sitting, certainly when we're breathing. So one of the things I like to start with when I talk about the discs is healthy discs,
Mhm.
keeping discs healthy through a lifespan, or as healthy as we can. And a lot of that involves breathing. It involves mobility. So maintaining the motion, particularly, I like to think about rotation as being a lot of what I work on a lot for disc health. And then also just maintaining that sense of axial elongation. We talk about this a lot, and I know, what the heck does that mean? That idea of decompressing the spine, using our core, using our other muscles to keep those spaces in the vertebra rather than slumping down into them.
Now,
And so, yeah,
absolutely. Couldn't agree more. So many times we have a tendency to think about an area of the body that is chronically injured
yeah,
as a negative. The piriformis gets a bad rap. The discs get a bad rap. Well, guess what? They are essential. They are essential to a healthy spine. They are essential to good spinal movement. And we really want to think of them in a positive way. And I like the fact that you're, you know, treating it this way, as we want to keep them as healthy as possible for as long as possible. And good movement is the key for that to me. It's
yes,
gotta be movement. And there's a
yes.
couple of reasons why. Number 1, they get their nourishment from the vertebral end plates, which are on the top and bottom of the actual, I'm gonna show on camera here, of the bodies of the vertebrae. On the tops and on the bottoms are vertebral end plates, and that's how they get nourishment. Well, guess what? How they actually do it is kind of like a sponge. The more you
Mhm.
move, the more you're actually pumping blood and nutrients in and out of your discs. So, the more movement we do, just standing up, sitting down, leaning over, bending forward, all of that can really help to nourish our discs. And the second thing is, I want to make sure that people realize as well to stay within a good, healthy range of motion, in that the entire spine are 26 joints working together, and that they can create a lot of flexion, a lot of extension, and lateral flexion and rotation. But we don't want to go too far in any one direction. We don't want to go too much, because that can also be an issue, just like in our knee. You try and extend it too far, well, guess what? Your bone's not going to like it very much. Your ankle's not going to like it very much. So we also want to consider that as well. So never force. I'm going to say that right now. Never force a stretch. A lot mobility
Mhm.
online right now, especially in social media. There's a lot of companies that focus on mobility, and it's great. I love mobility work. But you see the amount of movement that some of these bodies can do. Well, remember, these are either actors or athletes or models who have a very specialized body, who have been training for
Mhm.
years. And
Mhm.
maybe your body can't do the exact same ranges of motion. So respect your body's range of motion. Go till you feel a stretch. Don't go till you feel the point of pain where you can go just a half an inch more. No, 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 no. Respect your body. It will come over time. You can increase range of motion, but there are some limiting factors in the human body, and we want to respect those.
Just as an example of that, I think about Cirque du Soleil. If any of you've been to Cirque du
Mm,
Soleil, or you've been to a Chinese circus, or particularly Chinese circus is oftentimes where you'll see that, and you see the contortionists who can
yep,
basically turn themselves into a U. Like, they can
yep,
extend their spine to the point where their head is essentially over their butt, right? And that is a particular spinal structure. It is a particular ligament structure. These are people who are born with the ability to get there. And then I think
mhm.
about, for example, probably Brian, certainly my husband. Like, that mobility does not exist in that body. I just say you're not very foldable. Just like having to sit cross-legged under a table when we go to Asia is enough to make him just like not happy, right? So just thinking about, like, I think about spines as being like fingerprints. They are so unique. Every single person I've dealt with has different mobilities, different stiffnesses, different ranges of motion.
Yep.
It just varies so wildly. So very, very clear. I just want to underline this. I'm taking like a highlighter to what Brian just said. And if you are going on a mobility kick, especially for your spine, you really have to go, what does my spine do? How
Yep.
much does my spine move? You really have to take it as like, you got to own it. This is not about you looking like somebody else. That will only get you in trouble. Just really own that. Like, this is your spine. What can it do comfortably? And stick with that, gently improving that as you go, but really don't push it too hard. Thank you, Brian, for bringing that up.
Well, I have this client who I love her dearly. I have trained her for so many years. She is wonderful. But if I have her do a stretch where she drops her knees to the side like telescope arms, she wants me to stand on on her knees and push as hard as I can on her shoulders to get more stretch. I say, there is no way I would ever do that. No, 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 no. You do not force the body into contortions. Great word that it
Yeah.
was never meant to do.
Yeah. Yeah.
And yet I do see fitness instructors on the floor having people drop their knees to the side and twist their body. And I see them pushing on the client. And it makes me a little sick inside. Now, if you're a chiropractor and you know exactly what you're doing to take someone into an adjustment, fine. They're professionals. They know what they're doing. They've studied for that purpose and they know exactly what they're doing. For a stretch, listen to the body, go with what's allowable. I mean, you've watched me move. I've got good range of motion in certain ways and not so much in other ways. And you know what? I respect that. I continue to work at it. I'm getting better every day. But you know what? It's going to take time. Your husband, same thing. You know, we're both meant to be out in the field, you know, working with our bodies.
Objects with very stable
heavy
joints,
objects.
honestly. Like, he can lift heavy objects all day because his joints are super stable because they're not super mobile. And that works really well for what he needs to do.
So when we're talking about the discs,
Yeah.
I wanted to get into the structure of the disc a little bit.
Yeah.
So people understand. You hear anything from, you know, there's two different layers, first of all, where we have our center, you know, the nucleus pulposus, which is sort of that, the squishy middle. If you think of that jelly donut, it's the jelly. You know, it's a squishy middle. And if anybody's done dissection work, it's kind of like crab meat. It's usually well hydrated and kind of squishy. And then you've got, you know, the concentric rings around it making up the annulus fibrosus. Anywhere from, I've read in the literature, 8 to 28 concentric rings that are at various angles. You know, the fibers run at different angles in order to create sort of a cross hatching to create greater strength, you know, because if they all went in one direction, well, it'd be easier for the disc to pop out.
Yeah. And to shear in that direction.
And to shear, exactly. And something else that the reason why some say 8 and some say up to 28 could be a lot of different reasons, but think of it this way. The lower you go on the spine, the more weight and the larger the actual vertebrae are. So when you have a larger vertebrae, you're going to have more layers. You're going to have more of those concentric rings. Whereas in the cervical, we don't need as many. We probably don't have 28 rings up there. You have closer to 8, whereas L5S1 or L4, L5 has a lot more. And someone like me compared to someone like yourself, I weigh an additional 40, 50 pounds over you. So guess what? I have the need for more. And I used to be a lot larger in my past life. So guess what? My vertebrae are probably much larger and my discs are probably, built for that because it's had to sustain that, that weight for a longer period of time.
So what are this is a slight aside, but take this for a moment. If any of you have done dissection or played with those plastic bone sets that they have, right? If any of you've done that, and I know a lot of my students certainly have, so that's familiar to you. Just know that those bone sets are based on very small people. Very small people. And when I was doing a dissection years and years ago, there was a guy on the table who was probably 6'2" or 6'3", big guy, big muscles, big bones, big everything. And his L5, the body of his L5 was, I kid you not, the size of like a teacup saucer. So it was like, I'm putting my hand up, like it was this big compared to what you'll see with those plastic bones was, this big. Yeah. So just to put that in context, like it really, they can be quite large, those discs. So.
Yeah. And if you think about us just as people, some people are larger, some are smaller.
Yeah. Yeah.
And if we all had the exact same vertebrae, I'm thinking of, I have a Korean client who I saw yesterday. She's not even 5 foot tall. She's very petite. Her
Yep.
spine and my spine are going to be way different. Way
Exactly.
different. And that's okay. And again, someone who's 6'7" is going to be different than mine too.
Yeah.
So there's going to be
So,
some variability.
right. And so with that, you think about that wall. So there's these fiber angles go kind of at crosshatch fiber angles along the outside in the annulus fibrosus. And the idea with that is that they're supposed to contain, ideally, contain that nucleus pulposus. And the reason
Mhm.
that there is a nucleus pulposus, a squishy middle, is again so that force can go through that and be absorbed by that and then released by that.
Yep.
And what I would ask you to do, just even where you are, is just think about breathing for a minute. And if you breathe in, right, you feel like the rib cage widens, the ribs kind of expand out a bit. And what also happens there is because you put more volume into the lungs, you'll often create more space between the vertebrae. So even just on an inhale, it's like I'm opening up, like that sponge is not squished. And as I exhale, I'm very gently, tiny, just squeezing that sponge slightly. And this is where what Brian talked about that nutrition being transferred from those end plates into the disc and back out. That's a really important part of disc health. And a lot of why, they talk about disc health being a problem is because people don't move as much as they used to. And not only do they not move, but they sit, right? So if you're
Mhm.
sitting for a long period of time, like, many of your clients are, you are for your job, all you're doing there is compressing your discs. And this is why also most of us are shorter at the end of the day than at the beginning of the day, because literally we have lost that space in our discs primarily. Like most of that height is lost in our discs because we've squeezed the water out. We've dried up that sponge a
Yeah.
bit. And so again, breathing, movement in gentle ranges and appropriate ranges are really important for keeping that area going. And even after a disc injury, one of the things I find after disc injury, and why I want to say this here, is people stop moving. They get scared and they stop moving.
Yeah.
Like, back pain will do that to just about everybody. And the thing about a disc injury is, yes, you may need to really limit certain motions for a period of time, but don't forget to breathe. Don't forget to do the motions that you can do to maintain the mobility that you can in the rest of the joint and the health of the rest of the discs. So I just wanted to throw that out there as a before we get into the discs in detail.
Absolutely. And if anybody's had any back pain that involves spasm, I think that is one thing that will make someone stop moving almost more than anything else, because you go into a certain range of motion and immediately everything grabs and you can't
Grabs.
breathe and
Yeah.
and the pain
Yeah.
is pretty intense.
Yeah.
So you
Very stabby.
learn to not move because you're afraid of that happening. And
Yeah.
unfortunately, even when things have calmed down, you'll see that roboticness in their lumbar spine. They move very robotically because they're afraid of it coming back, even though things have calmed down.
Mm-hmm.
So it is important to explore your range of motion a little bit within safe ways. And we're going to talk about what directions are usually considered safe for disc issues, but explore that when things have calmed down to begin to increase that mobility again, some lateral flexion or some, gentle forward, little bit of forward flexion and more extension for, certain people, and just see what feels good and begin to get that disc to move again, to get that nutrients, those nutrients working. But I love the fact that you talked about breathing, because even just breathing and decompressing that can be a huge help.
And this is partly why, like for a lot of people, not everybody, but for a lot of people, walking with a disc problem is
Mm.
really, really helpful. And I think there's multiple things happening. I think one is there's a very gentle rotation of the spine. I mean, it's hard to walk stiffly enough not to move the spine at least a little bit. And it may not be
Mhm.
moving the lumbar, but it's stiffly moving the thoracic. So you're getting some circulation, you're getting some mobility. Gravity is again gently kind of squishing and compressing and decompressing those discs, and you're getting
Yep.
some circulation. And you're not generally in a flexed position. It's kind of hard to walk super flexed.
Yep.
Again, you can. We've talked about that with stenosis and learning to walk kind of flexed with stenosis. But with disc problems, generally when you walk, you're a little bit extended, and that often will pull that disc away from the nerves if that's the issue. So walking is a great way to think about just that gentle
Yes.
action of just keeping that moving.
And it's considered one of the one of the first things that they will give to
Mhm.
people with disc issues is gentle walking because
Yep.
it allows you to go into some extension and you're getting your glutes firing again and you are working against gravity. And believe it or not, when you walk, you're also having those low back muscles begin to learn again to one side flexing, the other
Yes,
side flexing
exactly.
with each step. The
Yep.
QL,
The
the
rhythm.
erectors, it gets that rhythm back.
Yeah.
And
Yeah. Yeah.
it's kind of a passive way to begin to work those muscles. And when I say passive to those muscles, unlike doing an exercise that's specific to that, they're
Yeah.
assisting. They're not the prime mover
And
for
it's just a
gentle
gentle,
walking.
like, tiny, as I always say, it just kinda goes go eek, 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 right? Just a
Yep.
small little range on each side. You're not doing a major range of motion. You're not going to end ranges at all. You're working in a very neutral range, if you will.
Yes,
Yeah.
absolutely. Absolutely. And think about the annulus fibrosis for a moment. This is how I've described it. Way, way, way back when you had a castle and you'd put walls around it. Well, guess what? The more walls you put around it, the better it is, the more fortified it's going to be. But something can still break through, or in this case, break out.
Mhm.
It
Right.
sort of chips away layer by layer. So it's like breaking a hole in one of the walls and then breaking a hole in the next wall and then the next wall. And that's really what's kind of happening to each of those concentric rings is that it's chipping away at that. And eventually it wears a little path,
Mhm. Right.
toward
Yep. Yep.
getting
Toward the
out,
outside,
basically.
basically
Yeah.
escape.
It's trying to escape. Someone's trying to
It's
get
trying
out.
to escape. Right.
So think of it that way. And when you do have a full herniation or extrusion, that's when it's finally, come all the way out. And that's when it can, again, impede on discs and things like that. And you can also have bulges, which we'll get into, where it's only partially through, but the disc
Mhm.
itself is sort of pushing out. And that can also push on the nerve root.
And a lot of that happens, like, that a lot of the people I know that have had an acute disc injury, it's because they were in a specific move, a specific position for a long period of time. Like, I think about,
Mm,
one of my friends who was, uh, putting in a floor in their workplace. And so they were down on their knees, which they don't spend a lot of time down on their knees. They're down on their knees for hours and hours, kind of days and days, about 2 or 3 days of kind of working down in a
yep.
crouched position. They're in some flexion, and that's when their disc finally gave up the ghost. Presumably it had been gently wearing away those annulus fibrosis rings over time, and then there was just this extended period of time which really did it in. So
Yeah.
a car ride, but oftentimes it is something like being on the floor with your grandkids for an afternoon or trying to do a science project with your 4-year-old, right? Those are the kind of things that will often create that trouble because you're down, you're flexed, and you're using your upper body in certain ways, putting stress onto those discs.
Most of the time, disc issues are going to be an accumulation over a long period
Yeah,
of time because they're pretty hardy. It takes a while to wear through those, and usually it is that event that is literally the straw that broke the camel's back. It's that
right.
last little bit that does it. But I've also had some people who say, I was picking up a pencil. I was picking up the
Right,
newspaper.
right.
Something that is so innocuous they've done a million times before,
Yep.
but for whatever reason, that position, they rotated, they bent funny, something happened, and all of a sudden, they came back up and, "Oh my gosh, I can't straighten up," and immediately the pain goes, through the roof. And again, it's an accumulation over time. That could have taken, the last 30, 40, 50 years of slowly wearing away that one, disc. And finally, it's that last straw. Or they are in that flexed posture for a long period of time over a course of a few days. I Working in the garden is
Yeah,
the one that
that's a classic. That's a classic in the spring.
absolutely. I just had a client who had it happen recently, pulling weeds.
Uh-huh.
And I said, "You're pulling a few weeds." She said, "I was pulling a few weeds." I said, "Oh, few in my brain is 3." So I'm thinking, "Okay, well, wow, all right." And she said, "Yeah." And I said, "Well, how long were you down there?" She goes, "Well, I was
Mhm.
bent over." So she didn't even kneel. She was bending over. She said,
Uh,
"I don't know, an hour?" It's like,
uh-huh, right.
ding, ding, ding. That's what did
Exactly.
it.
Now, it also can happen traumatically. So,
Car
Brian and I both
accident.
know a relative of mine who fell off a bicycle and ruptured some discs in that process. So, car accident, fall onto the spine, a fall from a distance,
Yep.
anything like that can certainly also cause some trouble there.
Yeah. Yeah. Especially if you land on your tailbone, something like that, which can,
Mm,
just that bang. I've
yeah.
seen people do that jumping off too high a diving board and landing, on their butt, so to
Right.
speak. You know,
Right.
they weren't ready. They weren't ready for the gravity to take them that fast, I guess. I don't know what
Right.
happened.
Oh, but gravity was not their friend in that
Not their
moment.
friend at that moment. But
Yeah.
yeah, so it can happen through trauma as well.
hmm So so a couple things about that. So once you have that issue, right? Once there's some part of that, either that disc is bulging and it hasn't broken through the wall and it's just pushing into the nerves, because again, that's typically when you're going to get symptoms. That's sort of version one. And Brian's got a visual up on the YouTube with just a little disc and it's a little bulge going out into the nerve. Um, Now, that's one thing. And a lot of times that is kind of manageable by just getting that disc to move away from the nerve. A little more problematic situation is something more traumatic when that disc has actually ruptured and you actually have what's called free sequestration or ruptured disc or degenerative disc disease, like something where really there's liquid that is coming from the inside of the disc into the spinal cord. The few clients I've had that have had that, that's kind of a chronic pain.
Mhm.
Opioids are not uncommon in that circumstance. And that's oftentimes where they may end up going into like a spinal fusion or something like
Yes.
that. So that's a much more severe situation. And then there's kind of everything in between there. One other thing I wanted to mention is that disc issues are most common between about 30 and 55, I think, 50, 55.
Yep.
And some of that is because after that, arthritis becomes more problematic. So that actually the number one, the spine gets stiffer. So sometimes there's just less mobility there. And oftentimes then the issue is more about, again, arthritis or stenosis or that kind of thing than a disc problem. And sometimes there's both. So just to, again, bring
Yep.
that in, that this is more common in that kind of middle years, just as a thing. If you've got an 80-year-old and they've got a back problem and they've got sciatica, you might want to think first about flexion and stenosis, and second about something like a disc. So just to put that in your brain.
Well, the thing that I usually mention to people is if you have something like a degenerative disc issue where that disc is no longer the normal height that it should be, like I have on camera right now, but it's really flattened out quite a bit. Well, when it's flattened out, there's usually it usually hasn't gotten much nutrients. It's usually dried and desiccated. It's usually
Yeah.
very stiff.
Yeah.
So that squishy middle that wants to push out because there's a lot of hydration, and like I said, it's kind of like crab meat.
Mm.
It's real moist. Well, it's no longer moist. It can literally dry out. So we're not going to get that center nucleus to want to
Right.
extrude out
That's
because
right.
it's dry or it's
Right.
drier than it used to be.
It's not
And
mobile and fluid and squishy. It's kind of like
yeah,
stiff and just kind of hanging out, going, "Ugh." Yeah.
exactly. So it's going to, we usually see this more in the younger, people. 30 to 55 is, classic age for that. What I've actually seen from disc issues is they've had disc issues up until they get to be about 60, and
hmm
suddenly that disc issue is not bothering him anymore. They've got
Yep.
other issues. They've got a little stenosis or something like that, but it's not
Yep.
the same feeling. It's not the
Exactly.
disc that's ticked off anymore. So it does change a little bit in that regard.
hmm So thinking about discs and thinking about injuries. So we've mentioned a couple of things already, and we've done this in different times. One of the things to think about with discs is that discs are most irritated by flexion. So
Yeah.
flexion and side bending are the two things that will push, right, compress the vertebra or squish the front of the vertebra or the side of the vertebra, which will push the disc material back toward the spinal cord. And most commonly, it will push toward one side or the other, either the right or left side. Sometimes you'll get symptoms down both, but usually it's just going to go to one side. And so a lot of our job as movement professionals and as coaches for our clients to try to help them feel better is to get them into positions which pull that disc away from the nerves and decrease their symptoms. That's really the strategy that we're looking at right there.
And a lot of people like to use the jelly donut sort of thought. I've also taught it as a ketchup packet.
Okay, I like that.
Because if you think of a ketchup packet, you squish one end, where does all the ketchup go? Goes
Yeah,
the other side.
Yeah.
You squish the other end, it goes the other side.
Yeah.
And if you stepped
Yeah.
on one side, guess what? It's going to squirt all the way out. So if you think of the disc that way, if you do flexion where you're squishing that front of the ketchup packet, well, guess what? It's all going to want to go in the back. And if there's a hole in the ketchup packet in the back, guess what's going to happen? It's going to leak out.
Right.
Whereas if you've got a hole in one side, push all the ketchup to the other side.
Exactly. I suspect some of you have done this before. I suspect some of you have had something like that where you just needed it not to squish out for a period of time. You're kind of like, you're carrying in your backpack or your pocket or something. That's happened. I've done it. I recognize this problem. Squish it all to the other side, get it away from that hole.
Exactly. And that's all you're trying to do here. So when you go into extension and you know that the disc wants to come out posterior and posterior lateral, well, guess what? By going into extension, you're pushing that disc material forward. You're getting it away from the hole and thereby hopefully pulling it back into the disc, where if it can come back in over, a period of time, you're never going to seal up the hole, but it's not going to want to always go out. So it can, I hate to use the word heal itself because it never seals the hole. But if that does recede back in there, it may stay there for a long period of time. I've had a number of clients with former disc herniations that have not had surgery, not had any problems once things calmed down, and they work to, create better core strength, better posture, all of that sort of thing.
Well, and also, like, I'm not sure that it doesn't actually heal up to some extent. I'm not sure the fibers actually stay open and the disc. So I'm not really, I would question.
It's more cartilaginous, so I'm not sure that there's much by the way of that. I don't know.
But because I know, like, a lot of clients, they say within a year, most disc injuries will resolve themselves. And that's what every doctor in the universe says. And that hasn't been my experience with a lot of my clients. And maybe my clients come to me because it didn't manage to heal itself up in a year. And that may be why I'm seeing them. But basically, it's like, again, moving that away. Again, there seems to be either the disc dries up a bit, which can shrink it. So there's a lot of ways where it can just decrease the amount of pressure that's being put on the nerves.
And again, looking at posture, looking at spinal position is going to be of the utmost importance in this regard. Extension does work best if they only have a disc issue. Now, again, if they have stenosis or something else, you may have to manage between the two conditions, whichever one's talking loudest. Okay, that is common. But for the client who just has the herniated disc, putting them into more of an extension position and teaching them extension, doing the McKenzie type of exercises, and you can go online and see what those are all about, that can really help to push that disc forward, or I should say the nucleus material forward in the disc, and take pressure off of the spine.
Now, I want to talk a little bit too about, because we're going to a lot of strategies in our next session, I think. Right? Our next episode of this will be specific movement strategies for both disc issues and or stenosis and sort of bony issues. But one thing I want to say is a lot of times what will happen, so if they don't see you, or maybe they have gone to a doctor before you, there's other ways that this is dealt with. So one is by doing an epidural, right, where they basically inject some pain-killing medication into the spine to decrease inflammation. Sometimes those can be helpful. I've had more than one client where they have an epidural, pain goes away, doesn't come back, life is great. I've had other clients, and epidurals are like this. Anywhere you get a steroid shot or a steroid injection, they're really variable. Some of them work great, clients love them, they're done. Sometimes they will feel better for 2 or 3 weeks, because that's often when the material is most active in the area. The anti-inflammatory material is active in the area. And then the pain comes back, either slowly or quickly, or it's better or it's worse. So something can happen. And the other thing I wanted to say about epidurals is just a thing, we haven't mentioned this before. Epidurals can damage the tissue that they're being injected
Yeah.
into. So a lot of the docs that I worked with at the Sports Medicine Center would say like no more than 3 epidurals in a specific area, the shoulder, the knee, the back, whatever, because it can actually degrade the ligamentous structures and some of the collagenous structures in the area, which can lead to more trouble. So just wanted to bring that up because sometimes that's a great solution and sometimes it's not. Then there's nerve ablation, which I've just started to hear about now, which is where they basically go in and they kind of deactivate the nerve in the area. And again, that I've had even more experience with it than I have, but sometimes again, that can work and that can decrease the pain and life is great. Sometimes it doesn't. And sometimes it does for a while and then things come back. So just understanding that there's some other ways that this is treated symptomatically. We haven't talked about surgery yet, but there's some different ways that that's dealt with.
And remember that everybody's body is different in the way it's going to respond to this.
Yeah.
Typically, when I've had clients with either of these, especially with epidurals, the first time works like a charm for about 6 months. So they get a period of time, 3 months, 6 months, but it's generally a longish period of time.
Yes.
The second time, and then the pain comes back, and then they go in. It's been more than 4 months. The doctor says, no problem. We can give you another injection. They get another one. The next time, it's a little shorter. So it's like half that length. So the typical one that I've seen is like 3 to 6 months. Then the second one is 1 to 3 months. It lasts. And the third one, maybe a month, maybe 3 weeks. And then after that, it's even less and less and less until it really isn't helping out that much. I've seen it with ablation as well, in that each subsequent one, you get less response. You get less positive response of pain relief. Now, could there be a lot of reasons for this? Absolutely. If you're a huge golfer, tennis player, pickleball, and you're very athletic or you want to stay active and you get the epidural, well, guess what? After a couple of weeks, you feel as good as new.
You go right back to everything you were doing.
You go right back to everything you were doing. And guess what? You can overstimulate the area and tick it off and cause it to come back. Whereas I've had other people who they're mostly desk jockeys, but they do work out, but they're a little lighter in their exercise. Well, guess what? Theirs last a little longer because they're not pushing their bodies to the extreme. They're taking care of their body, and we're working on core strengthening. We're working on training them properly to hopefully help them with this for a longer period of time. And I find that those are the ones that last longer in general, just in general.
Right, because they're not, I mean, because they're not just dealing with just the inflammation going down. They're actually looking at the root of the problem.
Yes.
Which most likely is how they're sitting, how they're standing, how they're doing whatever they're doing every day, whether it's their sport or it's their daily activities. Like that's most likely where that continual pressure is coming from. Yep. So if they don't manage that, if they just manage the pain, they don't necessarily get to the root of the problem.
And that's the issue. That's the issue, I think, in most medicine, is the treatment of the symptoms and not the treatment of the underlying root cause. Whereas for this, if we're working with a client who has a disc issue and we're teaching them how to have better posture, how to focus on more extension work. And let's face it, I remember I was in a class and I guess it was probably 6 hours in, someone raised their hand and the person was called down and they said, I just now realized how important extension is and how we don't do enough of it in life. How important. We need more extension. We need more extension. And it's very true. We live very flexed. I mean, you and I are sitting here. We're kind of in a flexed posture. I'm going to go from here into my car. Guess what? I'm going to be in a flexed posture, sitting at home, eating, watching TV. We're in flexed postures a lot. Now, as fitness professionals, we do stand a lot and we're moving and it's great. We can stay active, but we still involve a lot more flexion than we should. And for our clients, there's a whole lot more than just that.
And I say this all the time, every time I teach Pilates teachers. If you look at a Pilates mat program, it is primarily flexion based.
Yeah.
There's a little bit of extension. There's a couple of swans in there, and there's some side lying stuff, but it is really focused on flexion. And in some situations, that's a good thing. In many situations, that is not a good thing. So understanding that with a Pilates mat class, particularly, that you're going to have to modify if you've got clients in there with osteoporosis or particularly with disc problems, you really have to change how you think about movement and think about extension being something that most clients need a lot more of anyway. So like just really increase the amount of extension you teach is my basic clue. Whatever your modality, whether you're a dance teacher, whether you're a personal trainer, whether you're a group exercise instructor, whether you're a Pilates teacher, think about making sure you do extension for all of your clients.
It's balance. It's
It's
well
balance.
balanced.
Absolutely.
I remember, and I wrote about this in my book, professor of mine that you knew, Dr. Jam Prins. He asked us one day in class, he said, and this was when ab classes were all the rage and people were doing millions of crunches and all of that stuff. He said, okay, how many sets of abs do you do? You know, and I was doing like 24 to 30 sets in a workout. I was doing a lot of ab work because that's what you did. I'm talking way back when.
That was the thing.
And that was the thing. So, you know, and that was the average was between 21 to 30 sets. And he said, how many extension exercises are you going to do for your low back? And we all just sort of went, well, we might deadlift maybe once a week. We might do, you know, and really it was like 3 sets max.
If they were doing any at all.
If at all. And that's when it hit me. We need balance. And like you said, in Pilates world, you need to put in and make a conscious effort to put extension work into a mat program because it is extension based. And in fitness, same thing. So often we focus on core, but what do they really mean is abs,
right?
Without realizing, let's talk about the lumbar spine. Let's talk about getting them into extension because look, we lose thoracic extension too. So we need to focus on extension of the entire spine.
Yeah.
So it's something just to create that well-balanced approach when working with our clients. So when you are doing core work, if it's appropriate for them, put some extension work in. It's very important. And especially for someone with a disc issue.
Yeah. Now, one thing I want to think about with working with clients with disc injuries is if you're like most of the clients I've worked with, they have no idea where their low back is. You know, so if you're doing something supine, right, you're doing some laying down exercises of whatever kind, or sitting or standing or anything else, but particularly supine, and you say, okay, maintain an extended position in your lumbar spine, or maintain that curl, that position of your lumbar spine, right? They look at you like, excuse me? And even if they think they know, if you put your hand under their low back, right, or underneath, kind of under their waist, really, and just see what happens when they're doing their exercise, whether it's footwork on the reformer using Pilates examples or feeding straps on the reformer, and you don't cue them to do something, they're going to squish the low back as they push out, extend it as they come in. That back is moving all over the place.
Oh, yeah.
So creating dynamic lumbopelvic coordination is really, really important. And honestly, all that we've talked about in terms of a lot of the core work is designed to manage disc injuries. So a whole lot of the research and a whole lot of the way they think about neutral and all those things, we're looking at back pain generally, but disc injuries particularly. So really helping clients understand what that position is and when they're in the right position is critical. I use something I call supported neutral all the time with those clients who don't have much awareness or who have a very big lordotic curve, which just means I roll up something fairly soft and squishy and put it underneath their waist. So it's pushing them into extension, but so supporting the curve that they have and really finding that position and then having them be able to feel like, oh, I'm pushing back into that or I'm pulling off of that. You have to give people feedback for them to understand what's happening with their lumbar spine. They don't have a natural sense of where it is or what it's doing, I find.
You said the right word there is you need feedback. Proprioceptive feedback is so important. And if their lumbar spine is not touching the ground, if they're lying there and their lumbar spine, they have a neutral arc, they can't feel anything.
Yeah,
They don't
there's no
have
feedback.
proprioception. Right now, my proprioception is I can't feel anything in my hands because it's not touching anything.
Right.
Well, if my back is off the ground, I kind of know where it is in space, maybe, kind of, sort of, kind of. But if you put something there that helps you feel where that neutral is and gives you that support, but gives you the proprioceptive feedback that you're like, okay, yeah, now I feel where it is. And if I push into this, ooh, that doesn't feel too good. It gives you that immediate feedback of, oh, I need to be here. This is where I need to be. So it gives you that feedback. That's so important. I love it. You know, it's incredibly important to use. It's great.
And that's something where when somebody is standing up, they often are in a more natural extension, just being
Mhm,
upright, or even seated. If they're sitting kind of like on top of their sit bones, roughly,
mhm.
to give them that kind of cue, that will generally put their low back in a relatively neutral position. So standing, seated, they've got some feedback. Supine, they've got nothing.
Yep.
And since many of the beginning exercises that we do for low back pain, both in the personal training world and the Pilates world, are supine, I've got to help them get that basic understanding in that position that I'm going to exercise and move them in. Yeah, because otherwise we got trouble.
And if you've had anybody who's taken a group exercise class ever and has done anything in a supine position, as soon as they go to engage their abs, they're going to flatten their back. Every single one of them, because
Yep.
that's what they were taught. So
Yep.
many, and we taught that stuff years ago, but again, that's what they learned back then. So that's already programmed into what they consider to be exercise and core work and abdominal work. So when you put them on their back, how many of your clients do go right back, flatten that back out? So they need to be taught where their extended neutral spine needs to be.
The other thing too that I use when I'm working with that is it also gives them feedback. Let's say I'm going to have a client do a curl. Maybe it's time for them to start actually working into some flexion, but I don't want the flexion to go into the lumbar. Then if I've got a pad under there, I've got a cushion under there, then when they come up, I can say, okay, stop there. Right now you're flexing the thoracic, but you're not in the lumbar, and you come back down. Or if they're doing footwork or they're doing feet in straps, it's like, okay, keep that where it is. And I know Brian and I both harp on this a bit, so you're being harped on. And when we get into to looking at sequences, you'll get that again. Because honestly, the most powerful thing, and I think I've said this at every episode, I'm going to keep saying this, the most powerful thing that I can teach a client with low back pain is what position is optimum and
Yep.
creates the least pain for their low back, and have them
Mhm.
use that position in as many places as they can.
Yep.
Right. That's kind of that's the trick. If I can really get clients strong and stable and understand what's comfortable for them, and then what range of motion they can tolerate, like then my job is done and they can really manage themselves, which is, always my goal.
100%. Pain-free range of motion are words that come out of my mouth constantly throughout the day with clients because I want to keep them in a position where their body is going to have less pain to no pain.
Yeah.
And again, if that's more of a flat back position, then that works for that client. If it's an extended position, then it's for that client. And something to remember for these clients, it may not be necessary for them to ever change that position.
Hmm.
If flat back keeps them out of pain, but extension hurts it. I'll give you a perfect example, and that's me with my facet joints. They get irritated when I do too much extension. Well, guess what? I was demonstrating an extension exercise and I did 2 repetitions. And guess what? For about 3 days, I had a little bit of a discomfort. It wasn't pain, but it was a little discomfort. And I know that if I had done 2 or 3 sets, I would have had pain. I was literally just demonstrating an exercise and I know better. But I was in the moment. I did it and I thought about it later going, yeah, I probably shouldn't have done that. My body prefers flexion. I explore extension. I explore going into traditional neutral and I can stay there with no problem. But really going into extension, my body doesn't like it. So guess what? I don't go into it. I'll do thoracic extension. I'll do hip
Hmm.
extension, but I'll keep my lumbar where I know it's safe.
And I'm the opposite. So I had a disc thing and sacroiliac joint issues and other kind of things from being a dancer and a lot of hypermobility. And for me, like extension is where, not extension, neutral is where I live. And once I found that, and for a long time, I had a little lumbar roll in my car. If I was driving for long distances, I used to live in the Bay Area where driving is a thing you do a lot of every day. And it's something where if I do flexion, I can do, but I've got to be really, really conscious of what I'm doing. So if I'm doing a curl, if I'm doing a rollover, if I'm doing a short spine massage in Pilates in the apparatus, I can do it now and I can do it pretty comfortably. But when I'm coming down and I'm feeling that pressure could be going into my low back, I keep amazing core support through that whole thing. And I don't necessarily articulate really sharply each vertebra. Like I kind of go down to a certain point and then kind of go, okay, all my back muscles, my back's going down to one clump, right? I find the range that I can hold and support without causing any issues. And then I will just keep that as I go down. So just learning to control what's helpful, what's not helpful, what back position is most useful for you. And then how you commit to it. And,
Yes.
honestly, I don't have any disc issues anymore at all, unless I sit on my bike seat, but that's coming from something else.
But that's just it. For both of us, we know what's safe for our bodies. And as long as we stay there, we can
Yeah.
keep things pretty happy for the most part.
And do a lot of things. You and I are not like, I do a lot of stuff. I don't, it's not like I limit what my activities are.
No, and no one would look at either of us and think, "Oh, wow, they've suffered from a lot of back pain," which
Right.
both of us have.
Yeah.
It's because we know what's safe for our bodies, and that's my job and that's your job, and for all of us working with clients to figure out what position that client needs to be in to reduce their discomfort, but we can still strengthen them in.
Yeah.
And then teach them how to maintain that for either a period of time or forever, depending on the client and depending on their needs. For some people, it's temporary. For other people, it may be more long term. And then getting them to commit to that, feel it, own it, and be able to live their life there. And guess what? For a lot of clients we're doing so many things you'd never know they ever had back problems.
Right. Exactly.
We can do walking lunges, we can do we can do all sorts of things, but you know what? They committed to it. They've learned how to stay within their safe zone.
Yep, and they know what it is, and they can feel it in each,
And they can
right?
feel it.
They can hold it and support it. Because I think the
Yes.
other thing too, and we'll work on this a lot when we get to the programs, is there's understanding the position, and there's kind of working with that, and then there's learning how to support that optimum position in everything you do. And that strength has to come from the lower body, has to come from the hips, has to come from the core for sure, has to come from the upper body. And it really is looking at how all of those pieces come together to support the low back, because the low back really is the middle of a complex interconnected system. It does not exist in isolation at all. It's affected by the lower body, it's affected by the upper body, it's affected by breathing, it's affected by everything we do. So really understanding how to integrate that low back into the rest of the body is also something we need to then work on. Once we've got the position organized and we've started to train that and stabilize that, then we need to expand that out. And how do you lift something up? How do you do a lunge? How do you lean over? How do you pick something up while maintaining that position against a load with resistance over time? Yeah.
Yep. And one thing I want to put in here as well, you said it just a second ago, and I want to reiterate this. The back is low back is very complex. There's a lot going on. In that, you may see something that looks to be textbook, but if you're not getting the response that you expect from the exercises that you're giving them or the position that you're giving them, try something else. If an extension seems to irritate them further or bother them, guess what? Try something else. Put them more neutral. Put them maybe into flexion. Does that help? Does that hurt? If it helps, well, guess what? They may have something else going on here besides just the disc, and vice versa. Someone who has stenosis may not respond well in flexion, but extension, for whatever reason, seems to work better. Guess what? That's fine too.
Exactly.
Figure out what the person in front of you needs and work with that, because it is complex. You can have 20 different things going on. We both know someone whose MRI looked like that. It was like, oh my gosh, there's so much here going on. And you don't know what is causing what discomfort. So sometimes you just got to sort of play with that a little bit and not get so hung up on this is the only way.
One little thing I want to mention, this is just coming from my experience. So again, I was a dancer, I was pretty mobile, so things were a little bit wiggly. One of the things that I had to do for a while for my back was to stop stretching. I
Mhm.
actually had to really, and it wasn't that like, because as a dancer, I was stretching kind of extremely, because you do. It was just really to stop stretching and to focus on stability like crazy for really a couple of years. Once I finally stopped dancing and kind of knew that I had to deal with this, I was like, okay, I'm not going to stretch that. I'm not going
Yeah.
to loosen up that SI joint. I'm not going to loosen up that low back. I'm going to let it stiffen up a bit, because it needed the stiffness for stability. So that
Mhm.
was, again, that's not so common, but if you're working with somebody who's on the mobile side, just be aware of that. Like if they can't hold themselves together, don't focus on mobility. And partly I say that because having been to, a million idea conferences and everything, it's always like, well, mobility first and then stability. Generally, that's the right thing to do. But I've had, again, because I work with a lot of dancers and yogis and things, I've had enough clients where that was not the right way to go. They actually needed to only focus on strength and stability for a
Mhm.
period of time to stabilize the situation, to get the strength around the situation. So then they could actually go back and use some of that mobility. So just as a little caveat there for certain clientele.
Yeah. And I found with my clientele in general, stability seems to give them the most relief
Hmm.
because you're taking that joint and really, I hate to use the word lock it down, but you're creating greater stability within the joints, and that can help them create greater strength down the road. So I like to focus on stability first because mobility, especially with a disc issue, if you go in the wrong direction, you can keep reinflaming it. So I
Right.
do focus a lot on stability first. Again, for generalized, non-specific low back pain, mobility is great. It can
Yeah,
actually help.
it's often the key.
Absolutely.
Yeah, yeah,
But
yeah.
for disc issues, for stenosis, those type of things, a lot of times they need to be taught to be stable first and then work on mobility in a safe range of motion.
Right. Exactly. All right. So we've talked a bit about discs, a little bit about where they are, how to think about them, what to do. We've once again reiterated that you have to find the right position. Then you have to train that position.
Notice how that really comes about with this. It's like, look, find what position they can be in and then train them in that position. Hit them from all
Mhm.
angles, hit them from all sides, but keep them in that safe range of motion. And will that range of motion possibly change? Maybe. If it does, cool. If it doesn't, fine. But
Exactly.
focus on that first, and then you can train them. You can get them stronger. So, yeah, positioning is key for all things with the low back.
Yeah.
And next session, we're going to dive in a lot more with our strategies.
So exercises, progressions, where you
Yep.
start, how you
Mhm.
assess a client. A dynamic assessment is oftentimes what
Yep.
I'm thinking, right? So how do you assess them through
Absolutely.
movement, not just through like they're lordotic or they're this or that, not a static exercise, but what are you looking for when you're actually working with them? And then how do you build that up? So how do
Yep.
you not just leave them with a supine program that they can do for 10 or 15 minutes, but actually trying to get them into standing, get them into sitting, get them into walking, get them into more functional movements over time?
Yep. So that'll be our next session. So we're
Yeah.
going to talk about exercise strategies next time. Thank you guys so much for joining us. This hour went by very quickly, as these often do. Hopefully, you guys learned something about the disc. And again, hopefully, you realize that positioning is key. Once you get that, things become a little bit easier for your programming. Uh, Thanks for listening. As always, do us a favor, hit the like and subscribe button. And we appreciate so much for everyone who listens, and especially for those who do comment either on our Instagram, Moving Convos, or on our Facebook page, Moving Conversations, or on either of our own personal pages. Every single comment really does help to change the algorithms and make us a little bit more popular. So hopefully we'll come up higher in other people's feeds. So we really appreciate that. So yes, do hit the like and subscribe button. If you want to email us, movingconvos@gmail.com is the best way to get in touch with us. And for Nora St. John, I'm Brian Ritchie. We'll see y'all next week.
Bye, guys.